understanding left ventricular systolic function is tremendously important. And the question is, how do we evaluate left ventricular systolic function? As you can remember from your physiology, the heart has a systolic function and a diastolic function, or the heart contracts, and we call that systole, and the heart dilates, and we call that diastole. So the heart really have a systolic function and a diastolic function. And we can talk about the overall function, which includes the systolic function and diastolic function. So if you just sit back and think about it a little bit, the purpose of the heart is to pump blood throughout the body. If it's not contracting to push out a significant amount of blood, then that's going to affect the pumping function of the heart. If the heart is not filling up properly with blood, then it can't pump out sufficient amount of blood. So the overall function of the heart depends on the systolic function. That is when the heart contracts and pump blood out. And it also depends on how well the heart fills with blood. Because if it didn't fill properly with blood, it can't pump out a significant amount of blood. Today, we're just going to look at the systolic function, how well the heart contracts and push blood out. And the methods that we use, there are a few more that we didn't include here, but over the course of your study, we'll go over those. But the ones that we're going to cover here is ejection fraction. And we're going to define what ejection fraction is. And as you know, it's sort of self-explanatory. When you talk about a fraction, it is a something over something, you know, a third, a quarter, stuff like that. So when we talk about ejection fraction, it's basically the fraction of blood that's pumped out per beat. All right, and we're going to define that in a more precise term. Also, we're going to look at fractional shortening. We don't use this a lot, but it is mentioned tremendously in the text and in exams as well. So you need to know what fractional shortening. And it's just the fraction that the heart shortens. Remember, when the heart contracts, the walls come in. The septum and the posterior wall come together. So it's, you know, how much it shortens. That's basically what that means. And then wall motion score index. We divide the different walls of the heart into segments, and we started to introduce that when we did scanning views. Not completely, but we did start the introduction there. The different walls, we divide it into segments or regions. And when we look at each of these segment or region, we can say whether it's normal, whether it's a little bit abnormal, or whether it's very abnormal. And we have a scoring system for that. Stroke volume from your physiology, it is the volume of blood that's pumped out of the heart per beat. And we can use echo to determine that volume. Okay, so stroke volume is the volume of blood that the heart pumps out. So the left ventricle contracts. It is the volume of blood that the left ventricle pump out per beat, whereas your cardiac output, by definition, is your stroke volume times the heart rate. Okay, so these are basic definition. And there's one echo feature that we can use to determine whether the LV systolic function is normal or reduced. And that's what we call the mitral E-point septal separation. This is an M-mode measurement, but it is fairly accurate, and we use it to show you what that means as well. And then, you know, we look at the coronary distribution. That is the blood vessels around the heart and how they supply the different segments. because by looking at a specific segment, and if that specific segment is abnormal in its motion, you can determine the blood vessel that is involved. And that is very helpful because when we take that patient to the cath lab, we know exactly which blood vessel is going to be blocked, and we can prepare ourselves to treat it more effectively. All right, so let's look at these things in specific terms now. So again, when we talk about cardiac function, the heart has a systolic function and a diastolic function. We have a separate lecture to discuss diastolic function. And in today's medicine or cardiology, I mean, we talk tremendously about the diastolic function because diastolic function is very, very important. We used to think that just systolic function is important, but over the years, we have realized that diastolic function and diastolic dysfunction is very important because when someone develops heart failure, and heart failure is a syndrome, and we'll go over that, about a half of those patients is going to have a depressed LV systolic function, and then the other half is going to have diastolic dysfunction. So understanding diastolic dysfunction is very important because half of your heart failure patient will have diastolic dysfunction. So in specific terms, when we talk about cardiac function, it is the ability of the heart to pump a certain volume of blood per minute, and that is the cardiac output. Okay, so the cardiac output is when the heart pumps, and we usually talk about 5 liters of blood per minute. Okay, so if the patient develops heart failure, then usually they're going to pump out less than 5 liters of blood per minute. And it may be due to a problem with the systolic function, or a problem with the diastolic function, or a combination of both. Okay? All right. So again, the methods that we're going to use to evaluate LV systolic function, and we concentrate mainly on the left ventricle, but we can look at the right ventricle as well. The methods that we use to evaluate left ventricle systolic function: ejection fraction, fractional shortening, wall motion score index, mitral valve E-point septal separation, stroke volume, and cardiac output. So when we talk about the ejection fraction, as we mentioned previously, you just think about it. Ejection fraction, it is the percentage of blood that's pumped out of the ventricle with each beat. So when the heart contracts, it's going to pump out a certain amount of blood. To calculate, so this is all mathematical now, to calculate the fraction of blood that the heart pumps out per beat, you have to get the volume in diastole, then you're going to subtract the volume in systole. Okay, so when the heart is in end systole, it already pump out a certain amount of blood. To get that volume of blood that was pumped out, you subtract from the end diastolic volume the end systolic volume, and then you're going to divide by the end diastolic volume, and that is that is the mathematical formula for ejection fraction. Okay, if you have a container and it's filled with a fluid, and you throw out some of the fluid, and you can measure the volume at when it was filled, and you can measure the volume when it is lose some of its fluid. To get the volume that was lost or that you throw out, you subtract the volume when it was filled from when the from the volume that it was filled. You're going to subtract from that the volume that remains after you throw out some, and that will give you the amount of fluid that you throw out. So it's really common sense approach, even though we say it's mathematical. And to get the fraction now, you're going to divide the volume that was thrown out by the original volume that you had. Okay? So the ejection fraction is the volume in diastole when the heart is filled. At end systole, that means the heart pumps out a certain amount of blood. To get that volume that is pumped out, you're going to subtract from the end diastolic volume the end systolic volume. But we're talking about a fraction, so you have to divide that by the end diastolic volume. That is the ejection fraction. The normal ejection fraction is 0.55 to about 0.7. But we usually represent it as a percentage. So when we talk about ejection fraction, you'll see 55, 60, 70%. Okay, but in strict terms, it's a fraction. Okay, again, when we do this via echo, the echo machine will do the calculation for us. But however, we will look at the heart and see how well the heart is pumping, and we'll give an estimate. But when we do echo, this is done accurately. So what we do in diastole, we divide the LV cavity into small discs. So all we have to do is do planimetry around the border of the heart, the endocardial border in diastole. And then at end systole, we do the same thing. We do planimetry around the endocardial border. The computer in your echo machine will convert these into volumes, and it will give you an end diastolic volume, and it will give you an end systolic volume. And the computer knows to subtract from the end diastolic volume the end systolic volume and divide it by the end diastolic volume. So it automatically gives you an ejection fraction. The method that the computer uses a method we call the modified Simpson's rule, or the biplane method of disk. Modified Simpson's rule or biplane method of disk. And again, you have to remember this. So again, at the end of diastole, because the mitral valve is open, and all you do planimetry of the endocardial border, and then you drop a perpendicular from the apex. The computer will divide the LV cavity in these little discs, and it will give it a volume. This is the volume. So the volume the computer calculates is 84.6 mLs. Okay, it will divide it into these little discs. Okay, the biplane method of disk or modified Simpson rules. Diastole. In systole, it does the same thing. All you have to do as the technician is do planimetry around the endocardial border in systole, end systole that is, and of course you have your ECG in the bottom. Diastole is at the beginning of your QRS. Systole is at the end of the T wave or the peak of the T wave. Okay, and all you do planimetry around the endocardial border, and the computer will calculate the end systolic volume. It calculated at 49.4. So what the next thing it's going to do is going to subtract from this 84.6 your 49.4. That's going to give you the stroke volume, and then it's going to divide that by the end diastolic volume. You get an ejection fraction. So these are some normal values for end diastolic volume. Typically it's about 120 mLs. The range is about 65 to 240. The end systolic volume is about 50, but the range is from 16 to 143. Stroke volume, which is the volume of blood that's pumped out of each ventricle per beat, is about 70 mLs, and the range is about 55 to 100. The ejection fraction range is about 55 to 70%. Okay. typical value is about 58, 60%. Cardiac output, which is the volume of blood that pump out per minute. Stroke volume is per beat. Cardiac output is per minute. So the cardiac output is stroke volume times the heart rate. Okay, typical value is 5.25 mLs per minute, and ranges between 4 and 8. Liters per minute. All right. So again, this is how you do it. If your end diastolic volume is 120, your end systolic volume is 50. To get your stroke volume, your end diastolic volume minus your end systolic volume, say 70, divided by your end diastolic volume, which is 120, you get 0.58. So this is the ejection fraction. We usually represent it as a percentage, so it's 58%. Okay, so that is your ejection fraction. We usually talk about a fractional shortening as well. It's an older concept, but we still talk about it. And it's just the percentage change in the left ventricular cavity dimensions at the base with contraction. So it's just at the base, you're going to see how much it shortens with contraction. And this is a linear measurement. When we talk about ejection fraction, we talk about volume. Fractional shortening is just a linear measurement, and we can do it using M mode or two-dimensional echo. I know we have not done M mode, but the concept is the same. We measure the LV cavity in end diastole, so it's going to have a certain length, and then we measure the LV cavity end systole, it's going to have a certain length. So to get the fractional shortening, the left ventricular end diastolic dimension, we're going to subtract from that the left ventricular end systolic dimension, and we're going to divide it by the left ventricular end diastolic dimension, multiply it by 100. When we use M mode to do this, the normal value is more than 25%. So if it's below 25%, it's abnormal, and it suggests reduced systolic function. So with M mode, it's supposed to be more than 25%. And this is what it looks like. This is what our M mode looks like. And all I'm going to say to you, this is the septum, okay? This is the septum, and you can see the septum, it's going down and up, down and up. And this is your posterior wall, and it's going up and down, okay? These up and down movements of the septum and posterior wall is because you have systole and diastole. When you have systole, the walls move together, to each other. The walls move towards each other in systole. In diastole, they separate, they move apart. And you just think about it, you know, when the heart contracts, the walls move in towards each other. In diastole, they separate. So in diastole, the diastolic dimension, you just measure the length from where you have maximum separation from here to there, and that will be your left ventricular end diastolic dimension. Where they're closest together, then that is your left ventricular end systolic dimension. So if you measure this, okay, so this is your left ventricular end systolic dimension, left ventricular end diastolic dimension, where it separates the most, okay? So all you have to do is subtract from this, you're going to subtract this, and then divide it by that. That is a fractional shortening, okay? So it is the left ventricular end diastolic dimension minus the left ventricular end systolic dimension divided by left ventricular end diastolic dimension times 100. For M mode, it's usually greater than 25%. And when you're doing two-dimensional echo, it is the same thing. You measure your left ventricular end diastolic dimension, and we have shown you how to do this. And you measure your left ventricular end systolic dimension. We have shown you how to do this. and you do your subtraction and you divide by left ventricle end diastolic dimension times 100. For M mode, it's usually greater than 18%, and this is how it's done. So this is your parasternal long axis view. This is a diastolic frame because the mitral valve is open. So you measure your left ventricular end diastolic dimension. You measure your left ventricular end systolic dimension. So you can see that this is a systolic measurement because the mitral valve is closed, the aortic valve is open. Okay, so this is your diastolic, okay, at the tip of the mitral leaflet from the septum to the posterior wall. And all you do at the end, you're going to subtract your left ventricular end systolic dimension from your left ventricular end diastolic dimension, and you're going to divide by left ventricular end diastolic dimension times 100. The normal is greater than 18%. Okay, so fractional shortening is very important. There's another measurement. I am going to quickly go over it. I mean, the only time you will see this simplified quinone method is on exams. It's not done, in clinical. We don't do it on a routine basis, but you will probably see it in exams. And it's the simplified quinone method. When we look at fractional shortening, we look at the base of the heart, how well the base of the heart is contracted. But the heart also has an apex, and we totally ignore the apex. So the simplified quinone method incorporates apical assessment in the fractional shortening. So, but how he did this was he squared the dimension. So when you talk about a left ventricular end diastolic dimension, you square that. When you talk about a left ventricular end systolic dimension, you square that. So you square all his dimension, and then he had something for the apex. So when he squared everything and multiplied by 100, he had a factor called K, and K is the correction for the apical contraction, because the apex may not be contracting or the apex may be contracting. All right, so if the apex is normal, then K is 10%. If the apex is hypokinetic, then K is 5%. If the apex is akinetic, that means it's not contracting, then you had 0. If it's dyskinetic, that means it's moving in the opposite direction to which is supposed to be moving, you subtract 5%. And if it's aneurysmal, subtract 10%. So the simplified quinone for exam purposes only, all right? And then we come to the M mode measurement, the mitral valve E-point septal separation. So this is an M mode assessment, but it's fairly accurate. And the normal separation of the E-point from the septum should be less than 10 millimeters, 10 millimeters or less. Okay? The normal E-point septal separation should be 10 millimeters or less. If it's more than 10 millimeters, it suggests that the LV systolic function is reduced. All right, so we use it to classify ejection fraction as either normal or reduced. So we cannot give ejection fraction a specific number by looking at the mitral valve E-point septal separation. Or we can say it's normal or the LV systolic function reduced. Again, the normal E-point septal separation should be roughly about 10 millimeters. Anything greater than 10 millimeters suggests that the LV systolic function is reduced. And this is what it looks like. Again, this is our M mode down the bottom. We have a separate lecture to teach you everything M mode, but just to get you to understand this. This is your septum, as we showed you before. This is your septum. It moves up and down because when the heart contracts, the septum moves downward. When it in diastole, the septum moves upward. And then this is your posterior wall, as we showed before. But inside your LV cavity is your mitral valve, and this is what the mitral valve looks like. This is what the mitral valve looks like. And this on top is your anterior mitral leaflet. So on top, and you can see it repeats itself. And if you follow your ECG, which is on top, this is your diastolic frame. So the mitral valve opens in diastole. So when the mitral valve opens, this is what it looks like. And there are different points on the anterior mitral leaflet. This is what we call the E point. Okay, this is your F point. This is your A point, and your C point will be right there. And there's a D point right there. So this is your D point, your E point, F point, A point, C point. So this is your E point septal separation. You can see they are almost touching each other. That is what it's supposed to do. So this would be a normal LV systolic function. The normal E point septal separation. That's how much they're separated from each other, and you can measure it. It should be less than 10 millimeters. Okay, so you can use your M mode to determine whether the LV systolic function is normal or reduced by just looking at your E point septal separation. Again, your E point is right there, your septum is right there, and you're looking at how much it is separated. Okay, as opposed to this case, the septum is right here, and of course this is your mitral valve in the LV cavity. You can see that the E point is very far from the septum, so this separation is tremendous. So you don't even have to measure it. You know it's more than 10 millimeters. Okay. The thing about when you look in the M mode, so this is an M mode assessment of the LV cavity. On the horizontal axis, you have time, and on the vertical axis, you have distance in millimeters. Okay. All right. So we have looked at ejection fraction, fractional shortening, the modified quinone or the simplified quinone method, and we just look at the mitral E point septal separation. So now we're going to introduce the concept of regional walls or segments. We divide the heart into segments, and the reason for doing that is because the different segments is supplied by different blood vessels. And if we can look at a segment and determine whether the segment is normal or abnormal, we can accurately predict which blood vessel is involved in the process. So I'll tell you what, all right, so I am going to draw it first and then show it to you. Okay, so when we look at the LV cavity at the base, remember when we talk about the base, the mitral valve is at the base. So when we talk about the LV cavity at the base, the mitral valve is there. And we get the mitral valve is like that. Okay, you have so this is the LV cavity at the base. Okay, this is the mitral valve, the anterior leaflet is there, the posterior leaflet is there. So, of course, we introduced this concept when we did scanning views. This is the anterior wall, this is the inferior wall, this is the lateral wall, and this is the septum. Roughly speaking, that is correct, but the anterior wall actually stops about there. Okay, so all of this is the anterior wall. So this is your anterior wall. So let's call that A. Okay, and then your inferior wall is on the bottom. And let's call this I. So over here is your lateral wall, but we can do better. We can divide it into an anterior lateral wall. So let's call that AL, because this portion of the lateral wall is closer to the anterior wall. And we can call this our inferior lateral wall, because this portion of the lateral wall is closer to the inferior wall. So this is inferior lateral, so call that IL. So your inferior lateral wall. For the septum, we do the same thing. We can divide the septum into anterior septum, because this portion of the septum is closer to the anterior wall. So we call it our anterior septum. And then this portion of the septum is closer to the inferior wall, so we call this our inferior septum. So IS. So we divide the base of the heart. Let's label it the base, because the base is where you're going to get your mitral valve, a short axis, okay? So we divide the base of the heart into 6 segments, okay? We divide the base of the heart into 6 segments, and each of these segments are supplied by different blood vessels. So it's crucial. If you do your echo and you do your short axis at the base, and only the anterior wall is not moving properly, then you know it's a specific blood vessel, you know which blood vessel. So at the mid-cavitary level, that is where you're going to have your papillary muscle. So at the mid-cavitary level, you have your papillary muscle, okay? So you have one papillary muscle here. And then you have another papillary muscle there, okay? So this papillary muscle right there, we call this our anterior lateral papillary muscle, okay? And this is your posterior medial papillary muscle, okay? Anterior lateral papillary muscle, posterior medial papillary muscle. This is at the mid-cavity level. And we can divide the short axis at the mid-cavity level into 6 segments as well, using the same principle that we use for the base. So your anterior wall is right there. And we come down here, inferior wall is right here. Your lateral wall, you're going to divide it into 2 segments. This is your anterior lateral, just like we did at the base. And this is your inferior lateral. Remember, this is your papillary muscle, your anterior lateral papillary muscle. Okay. So over here, you have the septum, and we can divide the septum into 2 as well. We talk about your anterior septum. And this is your inferior septum. Okay. So we divide the mid-cavitary level into 6 segments as well. Okay. And this is your posterior medial papillary muscles. Posterior medial papillary muscle, anterior lateral papillary muscle. So the short axis, we look at the apex as well. Remember, we showed you in scanning views, we showed you how to get these views. So we can look at the apex, and to get the apex, the angle of your transducer is way up. Okay, so this is the apex of the heart. Okay. All right. So the apex only have 4 segments. Okay. This is your anterior wall. And down here is your inferior wall. This is the lateral wall. And this is your septum. So the apex only have 4 segments. But you can see this is 6 plus 6, 12, and 4. That's 16. So we usually talk about a 16 segment model. Okay. So at the apex, you have 4 segments. The mid cavitary, you have 6. And at the base, you have 6. Okay. Again, each of these segments are supplied by different blood vessels. So by looking at your echo, you can determine accurately which one of the which blood vessel is involved in the process. And this is what, let me erase this. Okay, so this is basically what is represented on the bottom. The apex, you can see there are 4 segments: anterior wall, inferior wall, lateral wall, septum. At the base where you have your papillary muscles, you have 6 segments. Sorry, at the mid cavitary level, you have 6 segments: anterior, inferior. The lateral, we have an anterior lateral, inferior septum, anterior septum. And at the base where you have the mitral valve, the same thing: anterior, inferior, anterior lateral, inferior septum. Okay. We also divide the apical 4-chamber view the same way. If you remember, this is the lateral wall, and this is your inferior septum. Or, so this is your inferior lateral wall, and this is your inferior septum. The lowermost portion is the base. This is the mid segment and the apical segment. So this would be your basal. This would be your basal anterolateral wall. Your mid anterolateral wall and the apical anterolateral wall. And then for your septum, basal inferior septum, mid inferior septum, and your apical septum. And sometimes we talk about the apical cap. In the 2-chamber view, where this is your anterior wall and your inferior wall, you're going to have a basal anterior wall, mid anterior wall, and your apical anterior wall. And then, the little topmost portion we call apical cap. And then for your inferior wall, you have your basal inferior wall, mid inferior wall, and apical inferior wall. And for the 3-chamber view, you can do the same thing. Remember what we said, with your apical 3-chamber view, this is your anterior septum. So you have your basal anterior septum, mid anterior septum, apical anterior septum, apical cap. And this is your inferior lateral wall. So your basal, inferior lateral, mid, and apical. So you can divide the heart into segments, and you have to know the segments. You have to know the segments, and you have to sit down and draw it and label it, and you have to do it accurately, because your further work in echo demands that you completely master this. Okay, so we're going to stop at regional walls, and on Tuesday we're going to finish up. Okay, but you need to go over the different segments, and on Tuesday we'll do a little bit more. We'll talk about how you determine a normal segment from an abnormal segment, and we'll talk about the blood vessel distribution to the different regions, and so we can tie up everything. Okay.